There is a focus on cost right now, and the cost issue is very tough to solve until you address the issue of the uninsured. So you have this, cost of the uninsured built into everything that we do, particularly in terms of reimbursement for healthcare providers. On the cost side, we have seen the government, move to reduce reimbursement, and private payers have followed some of that. In fact, right now, we're at very low levels of reimbursement in a number of the sites of care. In fact, to the point where I actually get worried that we're disincenting the use of some of the most cost-effective sites of care, including physician offices and even pharmacy, to be honest with you. Community pharmacy is definitely struggling, and it varies by state because Medicaid reimbursement does vary by state and has pockets of success and failure across the country. But we focused on now just cutting reimbursement. We've done that. Now we really need to look at how do we really improve care, support patient adherence, really look for preventative measures, and some of the encouraging parts of healthcare reform that I'm seeing private payers also emulate are things like covering with first dollar coverage for preventative care, and also incenting and rewarding patients for using the right site of care. So using a physician office or an urgent care setting instead of an emergency room, for example, or having care done in the least costly site of care by empowering patients with that data. The technology to support the kind of communication that we'd all like to have, where all of our healthcare givers know everything about us, it's not there yet. But we're making progress, and you're starting to see payers, particularly on the private side, begin to develop communication resources that empower patients. For patients to have information not just about cost, but also about their out-of-pocket obligation, is when you'll have patients then make decisions about where they have their care delivered. Electronic health records are a beginning, but the payers really control the back end of a lot of those resources, and that's where some of the most exciting methods are, because they can give that information back to patients in secure portal type formats. Physicians have really embraced the movement towards data. We've seen them move from e-prescribing, electronic health records. They've made significant investments in those areas, and in many ways they won't really realize the benefit of that fully until some of these newer care models evolve, so that they're sharing that type of data outside of just their practice. But there's efficiencies even within the practice, and that's exciting. And then long term, I think we will see reimbursement move to leverage more of these electronic tools. The pharmacy benefit side is much more efficient than the medical benefit side, but in the next 10 years, I think we're going to begin to see that piece change dramatically as well. The government has been supporting a number of investments, particularly for physicians and rural healthcare providers. Hospitals have also been making big investments, but most of the time they need to look at the ROI on that technology just for their facility, instead of really being able to look at that broader ROI of really sharing it beyond that one site of care. Technology is a challenge within the economy in general, and how do you fund that, and how do you assess whether or not there will be a savings from those technologies? The reaction overall from healthcare providers to healthcare reform has been actually overall positive. They really do bear an unfair risk in addressing the issue of the uninsured, and it varies. I think they're encouraged that we're moving forward with healthcare reform in terms of addressing the issues of the uninsured. We are seeing a lot of positive response from providers in terms of accountable care organizations and the medical home pilots that have been funded as part of healthcare reform. So that also is encouraging, because that means they really want to be part of that next wave of innovation. There's a lot of issues that are not being addressed, from a legislative perspective, because we do have healthcare reform, but also because of just the political climate where it's very tough for really any form of legislation to move forward. Track and trace legislation is one of the key pieces that was not included in the PDUFA legislation that moved forward. That's a critical issue for healthcare providers, from hospitals to pharmacies, and it's also critical to manufacturers. So it's an area of alignment and important in terms of patient safety, but also important in terms of cost, because we need one system in terms of the drug supply in this country versus allowing states to have each their own separate mechanism. For healthcare providers, I know there's a lot of concern about reimbursement. We certainly hear that loud and clear from physicians as well as from pharmacists. And not a lot is changing and moving in that right now, because anything that you look at in terms of reform can actually look like a cost increase. And again, the political and economic climate makes that difficult, but we certainly want those cost-effective sites of care, your community pharmacist and your community physician, to continue to serve patients. We know that that's going to be a low-cost, efficient model, and it's important to patients from an access perspective. A lot of people are speculating that, if we can't figure out healthcare reform, that we might just then leapfrog to a universal care model. And I'm somewhat doubtful of that. I think in this country we really like that balance of the private payer environment. And I'm probably more hopeful that we're going to leverage and utilize that private payer environment to then emulate that on the public side. So let private lead. Honestly, if we can solve the issue and get the uninsured so that 95 or 96% of Americans have coverage, then we get to a gap that really is manageable for healthcare providers and for communities to support. There's certainly pockets of the country where there's incredible poverty, though, and where we're going to need more support to be able to address that gap more quickly. But if we can figure out how to do that with private mechanisms, that certainly sounds like a uniquely American model. Value is a huge concept right now, and it's going to be important that as we talk about the word value, that we're transparent with that word, first of all, and that we look at it broadly. What we're starting to see is payers look at value from a much broader range. It'd be really unfortunate for us to make value decisions just myopically, comparing, say, one drug to another instead of looking at the longer-term impact of therapy. Looking at the broader, how is patient adherence impacted? How is patient outcomes impacted both short-term and long-term? How do adverse events impact the cost model of that? And looking beyond just treatment regimens, but to include other types of needs, other types of physician care, hospital care, etc. That's the impetus behind that innovation center, and that might be one of the more exciting parts of healthcare reform that could then actually trickle beyond the public side into the private payer market as well, because it would give us data to begin to really look at value and what that means. For manufacturers, there's a real opportunity right now to build that value story early in the clinical design of your products and then continue that on post-commercialization. And sometimes it means taking risks in terms of comparing your treatment regimen to other comparative treatment regimens, which is something that you didn't need to do in the past, but moving forward to really have the coverage and really the population use of a product, you're going to have to build that story. Publishing data is part of it, but it's really going beyond that as well to really say, what does that mean to a patient population, and use it at that payer level.